So good morning to all of you. I hope you all enjoyed New Delhi and the APAO and the AIOC conference here in New Delhi, and you had a good time. So this is probably one of the last sessions, and we have been conducting this course for past few years, and it's quite successful. We've got eminent speakers from all over. So I welcome Andrew, I welcome SJ. Paisan could not join us, so Dr. Piranat, if you're here, please come and join us. So he'll be speaking on behalf of Dr. Paisan. So I'm really thankful to all my eminent speakers, and we'll start our IC on vitreoretinal surgeon's nightmare. Our first speaker is Dr. Ajay Arora, who's my senior. I've learned a lot from him. He's a prolific vitreoretinal surgeon in India, and he'll be speaking on the submacular hemorrhage during vitrectomy for retinal detachment, how to proceed.
Thank you, Bhuvan, and it's such a wonderful course, and it's unfortunate that it is on the last day, the last session. I wish it could have been earlier, but let's anyway get going. So I'll be talking on submacular hemorrhage during vitrectomy from retinal detachment, how to proceed. Now, submacular hemorrhage during vitrectomy from the RD can be because of an inadvertent retinal damage. That can be either from a very senior surgeon who has become overconfident, where you touch the retina, or carelessness. It can happen while peeling a vascular membrane. It can happen during drainage retinotomy, where there can be inadvertent damage to the choroid or an adjacent retinal vessel. It can certainly happen during relaxing retinotomy if you are not very careful, or it could be a choroidal bleed from a laser shot, and I'll show you a case where we had it and how we managed it. The subretinal fluid can also, subretinal bleed can happen when you do external drainage of a scleral buccal, and then you may have to convert, and a subretinal bleed while draining the SP. So without why managing subretinal heme is important. It is because it causes physical separation of the neurosensory retina from the RPE, causing a photoreceptor loss. The heme becomes difficult to mobilize, and that happens pretty rapidly because of clot formation. And this clot can cause photoreceptor traction, and it can happen later on by a clot retraction, or if you are trying to pull the clot off, the photoreceptors may be ripped off while removing the clot, or later on when there is hemosiderin formation, which can cause the heme is toxic to the photoreceptors, and then you can have subretinal fibrosis. Now, generally, whenever it happens, how do we manage them? There are certain general measures which we take, and there are specific measures which we take in different situations. Please do not overlook any bleeding, because any bleeding can go subretinal if there is an associated break or a drainage retinotomy. You must manage the blood pressure and the heart rate, so you have to have a good anesthetic support. You should increase the infusion pressure when required, inject PFCL, or you can even mechanically block the bleeder, and if required, you can actually switch to air. You can add thrombin to the infusion, which I have not personally done, but there are adequate studies available which show that thrombin could be useful. And as many years back, which we don't do now, we were used to add adrenaline to the infusion. Now, other than that, let us see how these situations are. If you have taken adequate preventive measures, like in this particular case, where the BP and heart rate were well controlled, we had pre-treated the patient with an anti-VEGF. In this case, this is a very fibrovascular membrane. Now you will see that I am doing proportionate reflux. You can see those fluid coming out. We create a path which we have identified the place where we have to dissect these membranes, and once we dissect them out, if there is a hemorrhage on the retinal surface, it's better to mop it off rapidly, remove it before it forms a membrane. So in case you have a simultaneous chandelier illumination on, then this can also be done in a bimanual manner. So there's a study which has shown that intravitreal thrombin helps in controlling vitreous hemorrhage, but some of these cases do develop inflammation. I have personally not used, but I think this could be a useful tool in hands, and maybe somebody in the panel has been using it and will get their feedback on this. So I'll show you some cases. So there was a large subretinal bleed. PFCL has been injected. Once we inject the PFCL, it's a large bleed, therefore we create a large peripheral retinotomy. We can either do it with a hard tip, soft tip, or a snake, which goes through the peripheral retinotomy and that clot is removed, or sometimes we have to use an end gripping forceps for removal of the heme, and this is followed by fluid air exchange, silicone oil injection, or a fluid gas exchange, and it does well. Another patient who had a large bleed submacularly, the blood has been displaced by PFCL injection just above the disc. A drainage retinotomy has been created, and this heme is then removed so that the macula is protected. So it's very important that we are freely using perfluorocarbon liquid when required. Whenever the bleeding is not getting controlled and we have taken all measures, you can always switch to air, increase the infusion pressure, close all the ports and make sure that the bleeding is stopped and go back again. So this is an example of a blood being removed from just above the disc in a subretinal space, and this is followed by standard technique followed by fluid gas exchange, and the macula has been saved, the patient does well. This is a video which I borrowed from Dr. Subhendu, who had a massive bleed subretinally. He went ahead and did a relaxing retinotomy. First cleared the vitreous hemorrhage and then completed the vitrectomy, went in, did a relaxing retinotomy, injected PFCL. You can see him going in a subretinal space, picking up the blood clot and removing. Now, how many photoreceptors got damaged, we don't know, but yes, he was able to remove the entire blood clot adequately. The macula is clear. The retina at the end, you will see, settles fairly well. I'll just speed it up a little bit, and so this is how it looks like in the end. This has been lasered. This is another patient whom we had submacular hemorrhage. This was a patient with a retinal detachment where a standard procedure was done, had multiple breaks in the periphery. You can see those multiple horseshoe tears, and a vitrectomy was done. The case was going fairly well. After having completed the vitrectomy, we did a fluid air exchange. And this was followed by, under the fluid exchange, under the air, we did a laser, and this laser was topped up after silicone oil injection. And while I was doing this laser under silicone oil, there was a bleed, subretinal bleed from the edge of the break. Now, it was very important that since the blood was subretinal, it was a silicone-filled eye. I had to make sure that the blood doesn't travel to the macular area. So PFCL was injected over the macula in a silicone-filled eye. We tried to ensure that once we have the hemorrhage restricted above the arcades, it doesn't go submacularly. The endolaser was completed. Whatever blood we could remove from that area was removed. And we had a very thin film of blood in the end. Then the PFCL was removed, silicone oil exchange done, and there was a standard closure of the retina. This is how the patient looked like post-operatively, which the macula looks fairly clear. The patient's visual acuity had improved to 612 1 week post-operatively, and he is doing fairly well. Now, here I'm going to present a relatively new method of an improvisation which I've done. This was a 63 years old male, diabetic, poorly controlled. VIA surgery had been done in both eyes. Patient best corrected visual acuity was 6/24 in the right eye. The left eye was inaccurate. So we decided to do a silicone oil removal, extensive membrane surgery, subretinal TPA injection, and removal of subretinal heme with a silicone oil exchange. So this is how patient looked like. This was last year he had presented to us. So I'm sharing with you a device. Can you increase the volume? So this is a new one which we have made. This is a very the device has now been modified further, where the tuberculin syringe. So this was available by Med1, but it was not available at that time in India. So we made this device which couples a 10 cc syringe with a 2 cc syringe, and this is connected to the Constellation infusion, the silicon oil injection system, where the pressure is generally kept at about 8 millimeters of mercury. And when this pressure is on, we prime the tuberculin syringe, where you can see the TPA coming out, and this makes it extremely well controlled. This device, we are we have now almost perfected it, which could be used for subretinal injection in gene therapy. You can see the change in color. There's an orange color hue you get. We have gone subretinal, injected the TPA. This was injected at 2 places. This actually had a good sound. I don't know why the sound is not coming. But anyway, this was injected at 2-3 places, and having completed that, we did a silicon oil exchange. The eye was kept a little underfill, and this is the post-operative follow-up of this patient. The retina is quite ischemic in the macular area. All the membranes have been cleared from the disc. The heme has moved from the macula subretinally. So that is a way we can do these cases. Another thing which I wish to introduce is fibrin glue assisted hemostasis for persistent intraoperative optic nerve bleeding. And this is a case which has been shared by Dr. Mudit, which has been recently published. He got an award also for this particular methodology, and this is his small little video which I'll share with you of how he uses fibrin glue. And I think this will be path breaking in cases of where we have breaks which we can put a fibrin glue. Don't use a fluid gas exchange, don't use silicon oil, no tamponade, and we are able to settle the retina just by using a fibrin glue. So let me just, so here the fibrin glue will be injected over the macular area or over the optic disc area where there was a bleed. You can see the bleed there. Most of the blood is removed. The bleed was persistent. So this injection is being done now. So, and later on, once the bleeding has stopped, this membrane is just folded over the optic nerve head. A very intelligent way of handling an optic nerve bleed, which we find always difficult how to handle, and this patient did well. So take-home points are good systemic control, pre-op anti-VEGF injections, address any bleeding during vitrectomy immediately, avoid subretinal migration or membrane formation, liberal use of perfluorocarbon liquid, infusion pressure elevation may need to close ports and wait, can switch to air if required, judicious use of thermocautery, simultaneous aspiration with the thermocautery, so you have to have a bimanual system. And I have not used the fibrin glue, but yes, that could be a wonderful tool in a hand. Always do not panic, just sit back and see what you can do. In severe cases, one can always go back on another day and intervene. We have done it in the past, though it becomes difficult because membranes forms. And thank you very much, and thank you, Bhuvan, for this opportunity.
Thank you, Dr. Ajay. Very nice presentation. Although your topic was submacular hemorrhage during vitrectomy, you discussed all types of hemorrhages and how to control them. So I think the main purpose was if we have a complication during a surgery, or intraoperative, the thing is you should not panic. And I think Dr. Ajay has highlighted all the main things, what to do if you develop a submacular hemorrhage during a vitrectomy. Thank you, sir. Any questions from the audience?
Normally occurs either when you're putting the suture or it occurs when you're doing the drainage. The first thing is don't drain it. If you don't drain it, the blood remains fluid, and if you put the patient into a sitting position, it will settle down. If it's a very large bleed, of course, you have no choice but to go in and clean it up. But if it's a small bleed, it will generally go into an extrafoveal location. The mistake people make is that they will drain it. Once it's drained dry, it will become a clot. And that clot will settle on the fovea.
Can I make a comment? So increasingly we have new technology. I think Alcon is about to release the Unity, and we have other newer vitrectomy machines that can control pressure in the eye. So if you get a bleed like this, what would be your best way of raising the pressure to control the bleed really predictably?
So we normally, in our system, we can increase the pressure to 60 immediately by the foot control method. The Constellation has a system, we increase it to 60 with just a tap of a switch and it goes up. And one could actually use different instruments, which can be like even an, blunt-ended, like a Thanos scraper, which is not diamond dusted, but it's old, that can be pressed over the bleed and it can stop. Or even the end point of a cutter, because these are beveled now, that can stop.
So you raise the pressure to 60, and that might also be automated. So you just make one button, goes up to 60, and then when do you bring it down?
So that is the trick. That is the trick. So I think what we normally do is we raise the pressure, wait for the time, we consider the normal bleeding time. I, in my mind, count from 1 to 120 or 130, and I take the reservoir, go back and see if the blood has stopped. I just keep the pressure high, just see if the looks like the clot has formed, then I gradually bring it down and take a decision.
So I have to make a comment. See, this is not like a diabetic bleeding. This is a submacular hemorrhage which is happening. So you can't leave the ports. I think you have to increase the pressure, but you have to be very careful that the blood does not seep underneath the macula. So the most important thing here is that we should prevent the bleed to reach the macula.
Yes.
So I think immediately what you should try to do is raise the bottle height, increase the pressure and put PFCL so that the blood stays away from the macula. And if we have a clot, like you showed in one of your videos, which is away from the macula, we can even leave a small clot. But if the blood is underneath the macula, then you have to remove it by methods which you have shown, either by displace it by PFCL and then drain it, or create a large, you have to create a large retinotomy temporally, like a GRT, and then lift the flap and remove the blood. So the most important thing is, I think you have to act fast. You have to increase the pressure and you have to put PFCL and probably then locate the bleeder and probably try to close it with a diathermize it. And once you're sure that the bleeding has stopped, that is the time you should try to reduce your pressure and see whether it is rebleeding or not.
So the case which I showed you, the initial surgery had a bleed. We almost did a PFCL siliconal exchange.
Yeah.
Do you think that the gauge is important now? You know, we're headed now to doing 27 gauge, and I think we will see this in the next 1 to 2 years. We'll probably move that way. Do you think we'll have less of these problems, or we can manage them better?
So I think that's very true. See, the problems we face in India is reuse of our instruments. So when we have 27 gauge, it's very difficult to reuse them. So most of us use 25 gauge, and I agree that when you have a smaller gauge, you will be able to do a better tissue dissection. You can stay away from the blood vessels, you can save on blood vessels. So maybe in such a case, we'll follow a hybrid approach where we have the cutter going through 27 gauge and rest of it could be 25, or I could just stick to 25 and be happy with whatever I'm doing.
Great talk, Adriel. So my question is that when will you not feel bothersome to stop the bleeding? For example, in your case, the bleeding is coming up from the inferior part for the laser. After that, it's seeping toward the macula. But you know that, I mean, after this surgery, you have the patient have a prone position to displace the blood from the macula. So when will you look at that kind of case and you say, well, I'm not worried about this, and I have the patient have a tamponade and then coming without any intervention further?
Yeah, so that's what I did in that case. So when the active bleeding is there, I have to ensure two things. One, the bleeding, the heme does not reach the submacular area. So therefore, I have a PFCL bubble that prevents the blood from reaching the submacular area. Once it has got clotted, I'm a bit more relaxed that it is not going to move forward, and there is no active bleeding occurring at the point where it was occurring earlier. Then I can do a siliconol exchange. I can put in siliconol exchange and post-operatively ask the patient to be on a prone positioning, and that works well.
Okay.
We'll move to our next talk because we are lack of time. So our next speaker is Dr. Andrew Chang from Australia, and he has been a very great support for me in both APAO and APVRS. I think we all know him. He'll be speaking on my infusion cannula is not in the right position, subretinal or suprachoroidal displacement of the infusion cannula.
Yeah, thank you very much, Bhuvan. This session is nightmares, and sometimes you know you're going to get a nightmare and it doesn't happen, and other times it happens and it's pretty terrible. These are my disclosures. We have modern vitrectomy techniques which make surgery reproducible and efficient, but in some ways when things are really automated and quick, sometimes we end up in trouble quickly as well. I'm going to share with you some cases where we've had issues. So we put an infusion line in, and where do we put it in? Well, we have to be aware, obviously, of the surgical anatomy of the pars plana, but things can sometimes be tricky. Some patients will have an anteriorly inserted retina, and also where the oris serrata is varies from the nasal side to the temporal side. We generally would put a cannula in 4 millimeters from the limbus in a phakic eye and 3 to 3.5 in a pseudophakic eye. High-risk cases that we anticipate we're going to have a problem. Total retinal detachment with hypotony should really raise in your mind the very, very high risk of suprachoroidal or subretinal infusion. Trauma cases which potentially can scar the pars plana are another danger case. And when you are manipulating the eye to do surgery, that's also when things can go wrong. And there are patients where the eye's been rotated and the infusion can move. So a couple of tips. When this happens, I'm thinking in my mind, don't tunnel the incision with the trocar. Go straight in. Make sure that the infusion line is very, very carefully secured, and heavy liquid can help to stabilize the retina as well. So, confirming the tip of the cannula, it would seem pretty straightforward, right? So we will look from the side, we would use a forceps and push it in. That is, we directly visualize it. And it's happened to me, and it may well have happened to you, where it looks like we're in, but we aren't in, or we're just in. And as the eye rotates, the cannula can get out of position and be underneath the retinal or under the uveal layers. So this is a case that I did about 2 weeks ago, and I thought this was a really high-risk case. It was a case that was referred from the Pacific Islands. The vision had been very poor for some months, a chronic retinal detachment, large choroidals, pressures only 3, and I'm thinking to myself, we are going to have problems securing the infusion. So I walk into the operating room and say, I want a 6 millimeter infusion line, but I also want 6 millimeter cannulas on standby in case I need it for the instrumentation. So this is the surgery, and I'm not tunneling, I'm going straight in, 6 millimeters, and I look from the side and I'm not in. So I move in, I put my trocar in, I try and put my light pipe in to see where I am, and it glows red because I'm actually in uvea, and I can get in. Then I think I can come in from the other side and try to clear it, but that's no good. And so what do? I just make the infusion line from the nasal side. For some reason, and I've seen this many, many times, the infranasal port is often an access which has less choroidals. Many of the times the choroidals are on the temporal side. This is a case that my fellow was doing, and it was to be removal of a dislocated lens, intraocular lens, and she was preparing to remove it and suture 4-point fixation with Gore-Tex. So she's setting it all up. It's all going really well. I'm assisting her. She's making the infusion here. It's 25 gauge, all pretty straightforward. She continues to do the case really well. She's putting the first port in, the second access through the pars plana, ready to remove the lens and to suture the 4-point fixation lens. So case is going well, and you'll see that the lens is hinging on one side. We're really concentrating on getting this lens out. It's not easy, things are moving around, and I'm still, she's concentrating on the wound, I'm concentrating on the wound. You can see here that the IOL is being brought up. She's asking me, how do we get this out? Do I put it into the anterior chamber first? She's doing really well. She opens up the wound a little bit more, and we're so focused on what we're doing that you might look at what the infusion is doing, right? Both of us have not noticed this. She goes on to suture the wound. I said, you've got to be very careful here. Still haven't noticed anything. I'm watching her suture. I'm telling her how to suture. She's completely focused on a different part of the eye. And then I say, oh, your infusion line's about to come out. It's moved. And so we try to reposition it. We do get it actually back in, and we notice the red refocus has gone off, and we have got a suprachoroidal infusion with big choroidals there. We managed to drain some of it out, but the teaching point here is when we are moving the eye around doing things, that is when the infusion can come out. And industry is working on this. There are newer ways, and you will hear about it probably over the next couple of months, where you can secure an infusion line better. Just be very careful. It might be also at the end of the surgery where you're sclerally depressing with a cryoprobe, and the eye, the fornix is a little bit tight. So here, what did we do? Well, we abandoned the surgery in terms of suturing the intraocular lens. We did drain the choroidals, and then we're out, and about 2 or 3 weeks later, and the choroidals went away by the next day, we brought her back into the theatre again. But I said that we had an observer from overseas, when did the infusion line move? And no one saw it. No one saw it all because we were all so fixed on getting the intraocular lens out. So we went back, and this was a video that we had fortunately recorded, and it was out for a very long time. Now, this is a case of mine. It was to be a routine retina detachment, a pseudo-fake, very straightforward, and 23 gauge, and I enter, and I check it, and it's going all right. So as I'm doing the vitrectomy, I start noticing that I've got fluid, and furthermore, I've got more fluid than I started out with. And it suddenly occurs to me, probably about a minute or two into the case, I must have an infusion line underneath the retina. And that's why I'm getting this expanding fluid. So initially I think, well, I could flatten this off a little bit. So I make a posterior retinotomy and I try to remove fluid. I then direct myself, because I can't actually flatten it off. I see that my infusion line has slipped. It has gone now under the retina itself, and it's a pseudophakic eye, so it's a little bit easier. I try to free it up, and then I make another mistake. I think to myself, well, I can put air in. If I put air in, that will flatten the break at the top, and then I can drain it. But if you see now, I've got retina right up against my intraocular lens. The air bubble has completely dissected the retina and pushed it flat against the lens. There's vessels just behind the intraocular lens. So I shift my infusion to a place that I know is safer. I infuse, and you see, these are when it was non-valved. The air comes straight out again because it's all sitting up the front. And I clear the vitreous that's near where I accidentally infuse the retina. Here you may use heavy liquid as well to stabilize the retina. And it basically goes back. As soon as you get an infusion, you push it into the interior vitreous, it will fall back again. And here, heavy liquid is amazing. So we've stabilized the macula, we reposition and stabilize the peripheral retina, and then we can go on to do the case. And in this case, we went on to just use standard gas tamponade. So risks and intraoperative malposition. This is the other problem that you might have, and be very aware of this. When you are manipulating the eye, this is when the cannula can come out. We aim for long scleral tunnels because we want to reduce the risk of hypotony and wound leak, but we are losing length. So if you really think that the choroid is a bit thicker for whatever reason, enter straight in. And subretinal infusion fluid can cause iatrogenic breaks, tears or detachment like the one that has happened with me. Subretinal air is a real challenge, and I made a error in decision because I thought, well, I could just go to air, flatten that peripheral area off, and I'd be fine, and I could go posteriorly to my retinotomy, and that would be not an issue. But air finds its way under the retina pretty easily. So corrective steps, stop the infusion, reposition the line, and you saw how we did that in several cases. You can use an MVR blade to incise any tissue over the infusion line, but I will tell you that that often is not successful because it will move again. Use forceps to advance a retracted cannula until flush with the sclera. That was the case in which my fellow inadvertently did not realize that the cannula had shifted. I use 6mm infusion cannulas very often. If I suspect that there are any choroidals, even small choroidals, I will use that. And in these cases, don't tunnel the incision with the trocar. Thank you very much.
Thank you, Andrew. Wonderful presentation. I think he has just shown how a normal, routine, uncomplicated procedure can turn into a nightmare. So, and I think you've shown how to handle all the cases. If you could just highlight on what are the signs, once you have done all your homework, you have put the cannula straight, you have checked your infusion cannula, but what are the signs that you should be careful of that probably your cannula has gone into the suprachoroidal or the subretinal space? If you would highlight the points.
It depends on where it is anatomically. So if it's under the retina, that is, it's more superficial, it will be, the fluid is not going away. Like in my case, it took me a while to work it out. It was a bullous detachment to begin with, and often a bullous or subtotal detachment, the uvea will also be slightly detached. And I thought this is not flattening off. So sometimes with the bullous detachment, we can't see the break. So you start in the center, and as you move around, you know where the break is because the fluid starts to flatten. In this case, it did not flatten. And it took me a little while to work out that I was actually infusing into the subretinal space. The choroidal space is a little bit, I think you can sometimes get away with it. Because even though your infusion line may not be wholly into the vitreous space, in vitreous cavity, it can still infuse a little bit. So with my fellow, it actually was not too hard. We repositioned it and we kept on going.
I think this is
The
advantage.
reflex,
Yeah,
that's the
advantage
other
of
thing
the,
you were going, I think
having
you were
3
hinting
cannulas.
at. Yeah.
Any questions from the audience? Deepan.
Can I?
Can I?
Yes. Please. So can I ask you one or two questions? What is your impression when we used to do 20 gauge vitrectomy and used to suture the cannula? We had very limited displacements of the
Absolutely. Absolutely. And that's the teaching point. With technology now, things happen so quickly
cannula. Yeah.
because it's easy to do. You just enter and you just assume that that will be sufficient for the entire case. You're absolutely right. When we were doing 20 gauge, we were in with a large, with the blade. We would put it in, we would secure it with a suture and it did not move
Yeah.
during the case.
So,
So I think we are seeing more of it now.
So we just have
and
to be
so maybe in situations like you had your first case where you had choroidal detachment and such cases, would you like to have a sutured 6 millimeter cannula and do a hybrid vitrectomy?
Yes, you could do that, or you'll hear more about it because it's commercial in confidence. There will be some infusion lines that and cannulas that are shaped slightly differently, so they don't slide out so easily. So that is actually an unmet need for us. Yeah, that the cannulas will shift and move.
So now I think it's difficult to move to us back to 20 gauge.
Yeah.
So we have to improvise with the newer technology only. So please,
Yeah,
Neha, you wanted, Dr. Neha wanted to ask. a question,
Excellent
please.
presentation. I was just asking what Dr. Ajay has only asked, that the 6 infusion cannula, is it available for 23 or 25 gauge with Alcon or anybody else? Because if there is a case where I expect choroidal detachment, then I also go ahead and put, or in children quite often, put 20 gauge sutured infusion cannula. So because I'm not aware if it's there in 25 gauge, the 6 infusion.
Yeah, I'm not sure. I think it's
So-
only 23.
There is a company in Jaipur which makes a 23. It's not available from the routine this thing, which make 23 gauge 6 millimeter cannula. I got it made specially from them, and it comes with the name of Ovation. I don't hear about him more, so I hope the company exists. But if it does, they have this cannula available.
Because it is an unmet need, and both the cannula, the trocar cannula part as well as the infusion cannula need to be 6 Otherwise, either of them can slip out.
Yep, absolutely,
Thank you.
Manisha. Yep.
So can I ask the next speaker? We have the chief instructor himself, Dr. Bhuvan Chanana, a dynamic vitreoretinal surgeon. He'll be talking on uncontrolled bleeding during diabetic vitrectomy. Nice presentation, good cases.
So again, I would like to thank you all. Now, since we are discussing about nightmares, I think diabetic vitrectomy is one of the most challenging cases, and sometimes you can have a very severe uncontrolled bleeding, which can just hamper your whole surgery. So in diabetes, two things have to be avoided. One is creation of breaks, and the other is to prevent an uncontrolled bleeding. Bleeding, of course, will happen in a diabetic vitrectomy, which is unavoidable. So I always instruct when I was a teacher, now I'm into private practice, that whenever there is a bleeding, I ask my fellows, you should stop everything. You should stop the bleeding first, and then you should proceed with the surgery. Because if there is immense bleeding, then you can't complete your surgery. So it's like a war. So with the advancement in the instruments which we just spoke about, the visualization and the 25 gauge and 27 gauge, the incidence of bleeding has really come down and the outcomes have really improved a lot. But still, there is a very high probability of having a very severe bleeding in diabetic patients, especially in our country. They have got very uncontrolled diabetes. They come in end stage diabetes with very severe aggressive fibrovascular proliferation. And despite giving anti-VEGFs before surgery, we can face situations in which there is a very severe bleeding. So what to do? I'll just go by a step-by-step approach. So this is a patient in which I gave a preoperative anti-VEGF. I do now most of my surgeries with a cutter only, most of the dissection, sometimes use a bimanual approach. So there are mild bleeders here. If they're mild bleeders, there's nothing to worry. You can just increase the bottle height as discussed. And it's very important to monitor the IOP and reduce the bottle height once you are convinced that the bleeder has stopped. You can laser or cauterize these small bleeders as just shown. And relatively, this is a simple, straightforward case. Once you've relieved all the traction and you are successfully managed not to create a break, you just have to do a panaretal photocoagulation, and a no intraocular tamponade is also needed. So this is like a mild bleeder if there is. So as I said, if there is a mild bleeding, you can just cauterize the bleeder. A bimanual approach sometimes helps, in which you can just aspirate the blood, and with the other hand you can dithermize or photocoagulate the blade. Another point is sometimes try to cut the hyaloid from outside in approach. First cut the 360 degrees, then come closer to the disc, because if there is a major vessel near the disc or a fibrovascular proliferation, if you just burst it, there can be a very severe hemorrhage. So you have to be very careful. So I always prefer outside in approach, but in sometimes when there is a thick proliferation at the posterior pole, you have to start at the center. So as I said, the next step is, if the bleeding is not controlled, raise the IOP. It's very important to monitor the time, because usually the disc perfusion is usually compromised in diabetic patients. So you have to lower the IOP again and recheck whether the bleeders are closed or not, because sometimes what happens, we continue the surgery with a high IOP, and once we are closing the case and we reduce the IOP, the bleeding tends to come up again. So it's important to lower the IOP and check the bleeders. So what is the next thing to do? So this is a video I just showed. I did an outside in approach. So I'll clear all the vitreous from outside. Now there is a thick proliferation which is involving the disc. So just showing outside an approach. So once I've removed all the peripheral thing, now I'm doing the dissection with the help of a cutter only, involving the central frond. So all these bridging tractions are being removed. You can remove, these fine fibrovascular fronds, after removing all the tractions, can be, it's not necessary to remove all of these membranes. If they're not causing any traction, you can leave these rather than trying to remove these and create a break. So we have to prevent the formation of a break also, because then you will need some extra tamponading agent, which will probably even hamper the final visual results. So you can see most of my dissection, I think now everybody does mostly with these fine cutters which are available, and a bimanual surgery really helps in these. After that, you can just cauterize the bleeders. So I'll just go to the next case. So what happens if still there is a persistent bleeding? The next step would be, you should plug all your ports, and it is always better to use valve cannulas. Raise the bottle height and wait for some time. With the pressure, sometimes these bleeders stop, and you can proceed with the surgery after 2 to 5 minutes. However, still if the bleeding is continuing, what to do? So PFCL is a very important tool which I use nowadays if there is a persistent bleeder at the posterior pole. So the important thing is here that you have to not create any break, because if you created a break in the area of the traction and you are inserting PFCL, there are chances that it might go into the subretinal space. So in this case, there was a frond which is present just superior to the macula, but there was a persistent bleed also underneath the frond. So what I did, I injected PFCL. Once PFCL tamponaded the blade, it helped me to remove the membrane under PFCL. So PFCL not only stops the bleeders, it also acts as a third hand to support the retina and prevent the break. So very gently you have to do a tangential traction, because removing these membranes which are very adherent, with the ILM forces, especially if you're not dissecting, it can create a break. But in this case, it was successfully managed. So if there is a clot which is formed, a small clot is formed, you should not try to remove it because there might be a secondary bleeding, and these secondary bleeders are really much worse than the primary one. So let the clot stay there, and you can try to do an endolaser under PFCL, which is much more good because the PFCL presses the retina against the RPE. So this is a video in which something you should not do. So there is a clot which is present. I have completed my surgery. I have done a PRP. There is a blood clot which is present under the PFCL bubble. So as the video progresses, you'll see that I'll be very successfully able to remove this clot. And at that moment, I was quite happy. But at the end of the surgery, when I did a air fluid exchange again, the bleeding started again, and the clot was slightly much more worse over the macula. However, I did not then do anything because I knew that since I've not created a break, this small clot over the macula will resolve over some time. So the patient may have some delay in his recovery, but probably I will not have to operate again. So I've removed this clot under PFCL. And I think that I just thought that I've done a very great job. And you see at the end of the surgery, there is again this clot which is formed over the disc. So if there are small clot which are not over the macula and they're not bleeding, it's always better to leave it. So in this case, I gave a tamponading C3F8 agent to tamponade the bleeder to prevent further bleeding. So another case, just a diabetic case in which to show the role of PFCL, this was the tabletop tractional retinal detachment. After removing the vitreous, whole of the central macula is detached. It's a chronic old detachment. So I just injected a PFCL bubble again because there was a persistent bleeding from the underneath the fibrovascular front, and then gently just doing a membrane dissection and segmentation with a forceps and a cutter only. A bimanual approach would have been really good in this, but I managed to do it without a bimanual technique. So gently removing whole of this traction, the central retina, although detached, there is no break. So again, no tamponading agent needed. You can just leave air inside the eye. So I'm just lasering the peripheral detached retina, and the central detached retina, I'll just leave it as it is. So as such, there is no active bleeding and no breaks. So just a laser at the attached retina, and probably laser augmentation once this chronic TRD settles. So this is another case in which there was a persistent bleeder at one of the fronts. So this is a one-eyed patient. This is his only eye, and he had a thick proliferation at the periphery. I've done all the peripheral dissection. Now again, there is a bleeding which is coming from underneath the fibrovascular membrane, which is quite close to the macula. So in this case, I used a scissors to do the dissection. I injected a small PFCL bubble to tamponade the bleeder. I kept on tilting the eye to proceed with my dissection, and then again tilted to tamponade the blade. So continuous slide movement, and just my aim here was to give him a good vision. Just so this was his only eye, a vision in which he can just maintain his whole life without being dependent on anyone. So my aim was not to remove all the membranes. So I did a dissection, removed all the traction, and he was a young diabetic patient, lost one eye because of severe diabetes. So I just relieved all the traction, and you can see with the help of scissors here, the bleeding was controlled with PFCL only, and laser had been done before. So you can see some fronds of fibrovascular fronds are there. I didn't want to be very aggressive in this patient. The patient gained a vision of about 6/12 in this patient, and he was very happy. And this is the picture at 1 month. So you can sometimes leave these few fibrovascular proliferations which are not causing any traction, not need to be very aggressive. We have to give a functional outcome, and we don't have to have a good fundus photo. That should not be our aim. So still, if the bleeder is not localized, in very worst scenarios, if you have not created a break, what I do is I sometimes leave PFCL inside the eye and reoperate the patient. The most important thing is to not create a break, like in some GRT cases. So I have done it in few cases, just left PFCL, it tamponades, take care of the bleeds, and then probably after 5 days, you can go easily, and the bleeding usually stops, and you can give an anti-VEGF at the end of the surgery. So these are another techniques which I said sometimes when I just go at the posterior pole, I just create a small opening, a plane between the posterior hyaloid and the retina. So here what I'll do, I'll use PFCL as an agent to do a membrane dissection. So I'll just inject PFCL between the plane. In these two videos you can see. So PFCL, it just seeps between the plane of the retina and the fibrovascular proliferation and the taut posterior hyaloid, and it just dissects it. So it not only helps in the separation, it also prevents bleeding and prevents the formation of breaks, and also reduces the surgical time. So, but for this, you have to have a proper plane, you have to define a proper plane, and then you can just proceed with the normal dissection with the help of a cutter at all the edges, all the areas of the attachment. So, slightly you can become slightly more meticulous, and since there is not a recurrent hemorrhage which is happening because of the such a dense proliferation, I can just go proceed with my surgery and my dissection easily. Had there been a very severe hemorrhage, most of my time would have been spent stopping the bleed rather than proceeding with the surgery. So both of these cases, they went out quite fine, luckily, with the help of PFCL dissection. But you can't use this in every case, especially when the membrane is very tightly adherent, or you probably don't need it in much simpler cases in which the attachment is not very extensive. So as I'm doing the dissection, you can see that the PFCL will just continue to move and seep and also protect the further the retina and also prevent the bleeding in the first video. So these videos are around 2 minutes videos, so I think I have some time. So and again you can do the laser under PFCL only. That also sometimes gives some time. If there is a bleeder, the PFCL will remain there. It will press the vessel and it can further lead to the formation of a clot. So not only you get time, you can do you can complete your laser completely. Sometimes I even augment it with ARC, that is the anterior retinal cryopexy, at the edges and at the area of the ports, because you can have neovascularization at the area of the ports in diabetic patients, which can lead to post-op, maybe in a later stage, at a delayed hemorrhage. So you can see most of the cases, most of the dissection was done quite cleanly. In the second video, removal of these residual blood clots and membranes. And in both these cases, fortunately no breaks. So again, you don't need a tamponading agent like a silicone oil or intraocular gas. So I think this is most important. You should have a pre-operative workup. The blood pressure should be under control. Diabetes should be under control. It is better to stop the use of antiplatelets and anticoagulants, especially in these cases, because there are a high chances of intraoperative and postoperative bleed. So there are few studies which support it, although long-term outcome may not be affected, but the surgery probably becomes easier. And anti-VEGF, as I mentioned, pre-operative use of anti-VEGF has really reduced the incidence of bleeding. We should operate within 3 to 5, I think is late now. I think we should operate within 2 to 3 days after giving. It has really improved, reduced the bleeding and improved the surgical success rate. But we should keep in mind, once we are giving anti-VEGF agents, it can also worsen the tracheal retinal detachment. So be ready to operate at an earlier stage. So just to conclude in putting everything in together, I think technique is very important. It is very important to use valve cannulas nowadays. Chandelier system bimanual is a very good technique, especially if you are in the learning stage. And it always, I try to cut the hyaloid from outside in approach, but however, if there is a dense proliferation, as I showed in the last video, I can start at the center by creating a plane. So you can use in a bimanual approach, you can also aspirate and coagulate with the diathermy or a laser at the same time. Intravitreal anti-VEGF agents before the surgery really help to prevent intraoperative bleeding. You should never pull a fibrovascular proliferation which is present at the disc. It can lead to a severe hemorrhage, which is very difficult to manage, and it will compromise the whole of the surgery. And the use of PFCL I have highlighted. It really tamponades the retina, prevents bleeders. You can do a laser under it, and in worst cases, you can even leave PFCL inside the eye, and you can reoperate the patient after about 5 days. So thank you everyone for listening. Thank you.
You're the chair, but I'm going to take on your role. Can you tell us a little bit about leaving the heavy liquid in the eye?
Yeah.
And why you wait 5 days?
So the main role of leaving the heavy liquid inside the eye is that there is a very severe persistent bleed which I am not able to control. I'm not able to control means I can't go ahead with my surgery, so I have to abandon my surgery. So in those cases, I'll put PFCL so that the heavy liquid, and ask the patient to stay supine, it presses the bleeders and stops the bleeding, and it has really worked like magic in 2 to 3 cases. The important thing which we have to consider here is, in some cases, you can get a very severe post-operative inflammation with PFCL. So I think that should also not bother you. You can start oral steroids, and anyways, after 3 days, you're going to operate the patient again. So it can lead to a inflammation, but I don't think something which should really bother you. Start the patient on topical as well as oral steroids and be ready to take up the patient after about 3 days. Most of the times, in fact, all of the times I've used it, the bleeding usually stops. I'm not seeing the bleeders coming out again.
So the 5 days, I also do like you do. The 5 days is good because the clot will have liquefied. And the other advantage is not only it stops the bleeding, but the blood itself moves to the front part of the eye so you can actually skim it off. But as you've highlighted, there's lots of inflammatory mediators and sometimes staining of the lens, but it usually will settle.
So, taking that forward, Bhuvan, if you, when you inject the PFCL and there's a massive bleed happening, would you first do a fluid air exchange and then put in PFCL,
see, there are
or
other
would you
methods.
give a PFCL immediately and then leave it like that?
So as I said, we can go by a step-by-step approach. We can even mechanically press the bleeder if you are able to localize it. So the main thing is the localization of the bleeder. If I'm able to see the bleeder and I can close it, then that's not a problem. The problem is when I'm not able to locate the bleeding point because of the hemorrhage coming again and again. Doing a air-fluid exchange can work in some of these cases, but what now I prefer is to start with PFCL, because if air can work, then PFCL will 100% work better. So the main aim is to find the bleeder. If I'm not able to close the bleeder, and the moment I remove my PFCL, the bleeding again starts. So it will same happen with air also.
Have you cauterized under PFCL? Just a question.
I think I may have. I can't with a pinpoint, but I think I may have.
You can cauterize
Yeah, you
under
can,
PFCL. Shijen, you want to?
Yeah, I think if you cauterize in the PFC, sometimes just some a small bubble, but it's okay.
Yeah,
It's
you
very,
can.
very limited. Yeah.
PFCL does not stop the bleeding. It shifts the bleeding to the periphery. What happens is that the bleeding stops because you raise the pressure on it.
No.
Because you're not going to do just one, you're going to do both the things together. The PFCL helps because as you said, the blood comes up. So it not only comes up, goes to the sides of that PFCL also. So you have to be careful because it will form a secondary membrane at that level. It depends on where you've got the bleeding from. The basic problems come when the bleeding is at the disc. If the bleeding is in the periphery and the fraction has been relieved from that area, it's no-brainer. You will do the diathermy there. The problem comes when it's somewhere in the periphery and the traction has not yet been relieved. That's the time when probably the best way would be to shift to a bimanual approach and under a little higher pressure, maybe 40, 50, remove that traction area, clear that, and then diathermize it. If it's on the disc, that option is not available to you. You would have to take the pressure to maybe 60, sometimes even 80. See the point which is the bleeding point, and sometimes it will stop. You can actually combine this with mechanical support to the same area. So if you have a pressure of 80 and you add mechanical support, and normally what I'll do is I'll close the silicon tipped flute needle. I'll close it and then press it on that area. You see, that's soft enough that it will not create too much pressure there, but it's enough pressure to keep the vessel closed. And if you do that for a minute and then you take it off and then you bring the pressure down, if it stopped, great. But sometimes I've had a situation at least twice when that did not work. Now when that happens, the one time when the next step was, I had PFCL there, I had a pressure of 80, I cleaned up the blood from the periphery, and then I did a fluid air exchange at a pressure of 60. And after doing that, I put silicone oil, not PFCL. The reason for silicone oil was, I get a clear media and the blood will settle under the silicone oil. And then, as you said, it will liquefy over the next few days. And 3 weeks later, I went in, I had liquefied blood which I could remove. In fact, part of it I removed under silicone oil. Whatever was left, then I removed the silicone oil, removed that. The bleeding had stopped and I could complete the surgery.
So with with all due respect, I agree and disagree with all you also. So I fully agree for a peripheral bleeding, what you said was right. But so PFCL, it really stops the bleeding, which I have seen in my experience. There is no need to raise the bottle height once PFCL is inside your eye. It will do the same thing by pressure tamponading the bleeders. And in many of time, as I said, you can leave the PFCL for a longer time, do your PRP. In those 10-15 minutes, once you remove the PFCL, in 70 to 80% of the times, the bleeding usually stops. So at the disc, sir, at the disc also, it will stop. It will stop till the PFCL at least is there. So probably those are the cases in which you can leave
So
PFCL
Dinesh,
also.
how it works is PFCL has a specific gravity of say about 1.8 to 1.9 depending on what you use,
And
and on top of that you increasing the infusion pressure. So it's a double.
no, no,
Yeah.
sir.
So
Sir, the
the
PFCL will
weight
work very
plus
well,
the
even without increasing the IOP. And so secondly, I would, at my best, I would try to avoid silicone oil in a diabetic patient. If the only condition in which I'll use silicone oil is I've not lasered all my brakes. Otherwise, I will 100% try to avoid silicone oil, because if there is a bleed with silicone oil, then the patient is going to have a pressure of more than 40, 50 the next day, 100%. No, no, sir.
You've stopped the bleed. Your bleed is now localized under the silicone oil. If the pressure goes up to even 40, you have enough drugs to control your pressure for that temporary period. The important thing is you've got loculated blood, you don't have any membranes forming anteriorly, and anterior membranes are more of a problem than posterior membrane once everything has settled. And as you said, you've lasered. Your laser is complete. Only there's some area there's blood. You waited for the retina to settle down and lasered it, and now you're taking out the silicone oil and the blood. So that's the safest option for you. PFCL, on the other hand, does not work in terms of bringing down the bleed. That is a misconception. Only very small bleeds can stop with PFCL.
Okay, okay. Thank you, sir. Thank you for your comments. Let's, since we are short of time, let's go to our next speaker, Dr. Shi Jian Chen from Taiwan, and I think he'll really give some important tips and tricks for the management of the slippage of GRT, which is again another nightmare which can happen.
Thank you, Bhuvan, for asking me again for this nightmare symposium. Can I have my slide? Yes. Okay. So I'm going to talk on the slippage of giant retinal tail during the surgery. What do we do next? So this is happen in the case after you inject the perfluorocarbon, flatten down the retina, and then doing the free gas exchange, and then you happen to have this slippage. Now, in that way, you cannot use your back thrust to unscrew the retina again. You can see that's actually very heavy. So it turned out that the patient have a big fault like this. So every time I see this patient, I feel very sorry. Although the central visual acuity is okay, but it have some field defect. So what happened for this the slippage is that because you have incomplete subretinal and vitreous fluid removal. So the aqueous, when you have the perfluorocarbon, the surface tension of this retina is actually, the flap is actually sit on the perfluorocarbon, and then you have a space for the aqueous. And when the air come in, and then you can see that the subretinal fluid was sequestrated underneath the retina, and then when you are going further with the gas, this fault because of the gravity, they come lower even onto the macula. So David Wang suggests that if you want to have the perfluorocarbon liquid, you should have this perfluorocarbon injected until it comes up from the infusion channel stroke, so that makes sure that the eye is totally filled with the perfluorocarbon. So when the macula is on and the slippage is mild, so what should we do? In this case, you can see that when we open up this retina, there's some grayish shadow at the side posterior to the retinal brake. And this area actually have some intraretinal contraction, like a PVR change. So I made some radial cut for these patients. I try to conform this shape of this detached area to the choroid. And when I saw this picture, you see that actually the radial cut is not deep enough, so I should extend until the edge of this PVR area. So you can see that you can have a better perform this retina. And then when you try to have this fluid exchange, be careful that you have to put your extrusion tip from the posterior to the anterior so that you can make the retina sitting well on that. So why is that we use a radial cut? For example, you can see that this radial cut can open up the inward tension and drain the posterior subretinal fluid. So you have A and B. If you cut deeper, then you have more chance to aspirate the trapped subretinal fluid. And this will be shown in the mathematical model for a 90-degree tail without or with radial cut. So if you have no radial cut, the gravity will draw the subretinal fluid towards the posterior. You have a radial cut for 3 millimeter, it's like this. A deeper radial cut, you can have a less subretinal fluid trap at the center. So if the fold is not great enough, it's at the side of this macula, it's an extra macula area, then probably you can have some retinotomy here, drain some fluid, but still the slippage was folded, and then you have a epiretinal membrane, a large pucker for these patients. So the other way is that you can have this air-oil exchange to alleviate the slippage. For example, in this case, you can see that after the perfluorocarbon liquid, try to have this free gas exchange. And you can tell that during this free exchange, even with I very carefully drain the subretinal fluid, there's still fold over the area. In this case, I changed to a silicone oil, and then the fold was become less. So the reason for this is because of the buoyancy force, and the surface tension force is different between the silicone oil and the air. So you can see that on your left side, you see this air is have a very strong buoyancy, and then also the tension. So on your right side, you see this folding here. So the fold depends on the force in the posterior part, posterior to the fold, and also the anterior to the force. And also you have a buoyancy. And because of the silicone oil, it have a less force and less buoyancy, so you can have this less severe retinal fold. So in case of that, you see the fold, probably can change to silicone oil. The other thing is that this has happened when I have these patients. The patient have a lower retinal detachment and anterior PVR with silicone oil. So this patient come to me, and I try to think that maybe after this relaxing retinotomy, I can just inject the perfluorocarbon underneath the silicone oil to the tamponade and flatten down the retina underneath. So I inject the perfluorocarbon underneath the silicone oil after the lower retinectomy. And it happened that the adhesive silicone oil and the perfluorocarbon became a large bubble, and because of the buoyancy of the silicone oil, this big bubble float up, and it takes the retina detached from the posterior. So then I have to aspirate the silicone oil to decrease the buoyancy, and I make more radial cut for this patient, and finally I flatten down the patient, and then I do the oil exchange, the free perfluorocarbon and the silicone oil exchange to flatten down the retina. So what happened? What is the mechanism for this? This is called a sticky silicone oil syndrome. So when you have the perfluorocarbon at the base, and then also the silicone oil, if the silicone oil has a very good contact with a large amount of perfluorocarbon, it will look like this, a big bubble. So this is buoyancy of the silicone oil is not sufficient to overcome the interfacial energy. So we have this case like I shown. But in other words, we can use this as to squeeze out the subretinal fluid. So when you have an oil-oil exchange, you have a silicone oil coming in instead of, and you contact with the perfluorocarbon. Then they form a very smooth surface that can squeeze this subretinal fluid. So make the slippage less likely. I want to show another case. This is a patient with a chronic retinal detachment. This is pre-op picture. You can see this previously have a big hole there. And I tried to peel the anterior PVR, which was hard to be released. Then I follow this with relaxing retinotomy. And I also do some radial cut, try to flatten down this relaxing retinotomy. This the giant tail I created after the retinectomy. And then I keep on working on the anterior PVR. Then I inject the peripheral carbon, and then continue to peel the membrane like this. And I have a high buccal for this patient. Now I start to have the anterior PVR at the lower retinectomy. Then I use a frequent exchange under the peripheral carbon. Also, oil exchange to avoid the slippage of this retinal fold. And the patient become okay after this surgery. And this has a post-op 3 days. And this 22 months later. I still have some useful vision, although the retina of the macula is still very thick. So you can see that the buckling prevents the anterior PVR happen in the superior part to involve this macula. And although there are some PVR change at the nasal side, is okay for these patients. The other thing, the last thing I want to show you is that you can also perform the two-stage procedure for this kind of PVR to avoid the slippage. Now this is a 30 cases retrospective study from the Belfast. And they use that peripheral carbon not only in the intraoperative tool, but also the short-term post-op temporary for 1 week. So after 1 week, they take out the peripheral carbon and they inject the gas or silicone oil. By doing this, they decrease the rate of slippage, which is 0% for this kind of a procedure. And they have a redetachment for 9%. Then have a silicone oil tamponade compared to a traditional one-stage procedure. They can have the silicone oil tamponade for only 23% of these patients, compared to the previous one-step procedure is 80%. And also, especially for those fresh cases without a macula involvement. So as Boomer already showed, that if you put the peripheral carbon for 1 week, there will be some mild anterior chamber inflammation that can be easily controlled by the topical steroid. And during the 30 cases, one case I have a persistent peripheral carbon drop it in the anterior chamber. So what if you have done peripheral carbon and you have to have this inferior relaxing retinotomy? This is a case shown by Professor Xu. She showed me that you can have this pre-pressed diastemy, and then you have a free exchange drainage from the posterior retinotomy. Then after the air filled in, you can have start your relaxing retinotomy. So the retina will be contracted toward the posterior, but you can still have this procedure after the laser and then the silicone oil. So in summary, to prevent the giant tail retina slippage, you should dry the subretinal fluid and vitreous aqueous as much as you can, and radial cut to make this flap more more well fit to the colloid. And you have a silicone oil temporary to decrease the fold, and also a silicone encircling buckle to avoid the future PVR changes if this patient already have some PVR. And during the intraoperation, macro fold, if you happen, I think you have to re-inject the peripheral carbon to release the fold. It's not easy for a macro fold to be flattened down. If it is an extra macro, leave it. You can use a very small retinotomy and change to oil tamponade to flatten down the flap. And then you leave the peripheral carbon. This is another choice for 1 week, and you have the second surgery for the gas exchange or silicone oil exchange. So I want to thank my colleagues, and thank you for your attention.
Thank you, SJ. Excellent presentation. I think very useful tips. And I think those radial cuts, they are really very helpful. I routinely do it even before I do a food exchange. They really prevent slippage. I just have one question for you. What intraocular tamponading agent would you decide for your GRT cases? Not the complicated ones. Which is your preferred intraocular tamponading agent?
I'm sorry, you mean which kind
Gas
of
or silicone oil at the end of the surgery, which would you like to use and why?
Yeah, like I said, I mean, if you happen to have a slippage, then probably you can shift to silicone oil to decrease, to a compression of the fold. But anyway, I mean, this two-stage paper show that if that is the case, and it is a very fresh retinal detachment, the macula was well attached, and you think that this probably will cause a slippage. So maybe you can leave the perfluorocarbon there for 1 week, and then go in.
So that is your preferred approach now? You prefer to leave?
Actually, I haven't tried this two-stage before. So I'd like to try that. But anyway, I think I will try to avoid the slippage as much as I can. So, and then change to gas, if it's a fresh gas.
So I have done few cases with the two-stage, and I think it works really good. I think Andrew also must have done it. There are few papers from Australia also, and I think it really works very well, especially in young patients who have a very high chance of developing PVR and contracture and slippage. It really prevents the risk of redetachment.
Yeah, it's a really nice technique, but you do have to go in a second time. So there are, you know, convenience and cost issues to go back in. Just one question to you. Macular fold after regular detachment repair, how do you reduce that? I'm not, you know, like in terms of post-operative posturing, how much fluid air do you do? Because that's actually a really big issue if the macula's split or just off and the next day you have a fold through it.
Yeah, are you meaning the intraoperative or post-op you happen to see the fold?
Post-operative, you see the fold.
Well, that's very difficult. I think you have to go in and then inject the fluid, the BSS, to the macula, detach the macula, and then the perfluorocarbon again, and then try to further.
Sir, I said as I would always prefer gas only if there is no slippage, and if I'm leaving PFCL, then also I would probably, for a young patient, I would probably, first again gas only, but for a young patient probably I'll go for silicone oil because both positioning and follow-up is slightly difficult. Yeah, I agree with you, but my preferred approach is I do a PFCL. I always, even if I'm using silicone oil, I will always do a PFO air exchange to see whether there is any risk or not. I've relieved all the traction or not. I don't prefer to do a PFO silicone oil exchange direct.
I have one small question to Sir, you and panelists. Sir, how you decide how many radial cuts for a particular degree of GRT, like if it is 180 degree or 270 degree, the white portion you were showing in your video, how to decide and how deep we have to make the cuts?
Yes, like I show, I mean, it depends on the how big is the extent of this radial cut. And then I know there's one doctor, he showed us that you can just make a long radial cut at the edge of the tail. But I mean, even if you're doing that, when you are trying to spread, doing the free gas exchange, you still see some folding of the flap. So I think that's the time that you start to do the radial cut. So sometimes I just make this after the perfluorocarbon, and then I try to see during the free gas exchange, I try to see if the flap is coming, I mean, the folded. So in that case, I will do that area, the most depending part to do the radial cut. If it's not enough, and then I'll do another one.
Sir, there is a PVR in the margins of the fold, and many times we cauterize and trim that. So we are doing that step also, and we are giving radial cuts also. Like both the things, or it is like one is going to substitute for that step?
I think if it already have some PVR change, that would be much more difficult, and maybe the radial cut should be deeper. So, yeah.
I think radial cuts, they have a different role also. So there are two tractions which act in GRT. One is a longitudinal traction and one is a radial traction if there is PVR. So I think radial, with the radial, these cuts, you reduce the radial, the tangential traction also. So we are reducing two forces. So if you saw in the video also, the retina tends to open up like this.
Yes, sir.
So there are, if you're trimming the edges, I think these radial cuts, they relax it. Yeah, they relax it radially, tangentially. So always they will always gape. So in slightly old cases, there is always some contracture tangentially also. So I think you should do these radial cuts along with the trimming of the margins.
And how many? Like
How many? I think it depends. You can't define it. I think it will depend on the amount of PVR and shortening which is there. For a very simple case, what I prefer is I'll make two at the edges and one in between or two in between. But probably if the PVR is severe, then probably you have to make it for about 2 days diameter and also increase the number of them. But I think it's very difficult. It has to be decided intraoperatively only. Like a retinectomy. You can't pre-decide a retinectomy.
Thank you, sir.
Thank you. I think since
Thank you.
we're short of time, we can go to our next speaker. So Aizan is not available. So in place of him, Dr. Piranat is available, and he looks like a very young, budding veterinary surgeon from Thailand. So please, Dr. Piranat, he will speak on the intraoperative suprachoroidal hemorrhage management. Is there any hope left?
Okay, thank you very much for having me here. Today I would like to talk about is there any hope left in the intraoperative suprachoroidal hemorrhage. Okay, so, speaking about the hope, so I can guarantee that there is no very terrifying movies or video in this slide. Okay, so I have no financial disclosure. So, speaking about suprachoroidal hemorrhage, everyone knows that it is, even though it's uncommon, it has a highly devastating intraoperative complication that can cause the permanent visual loss, and it is actually the bleeding from the choroidal vessel into the suprachoroidal space can cause it by the sudden compression and decompression event that it can cause a rip in the choroidal vessel and leaks of the blood into the suprachoroidal space, which is the potential space that can expand that can expand and cause the damage. And it's caused by the impeding vortex venous outflow from the retrobulbar anesthetic injection or retrobulbar hemorrhage and any excessive pressure in the back of the eye. And the final visual acuity is also very unpredictable from very good visual acuity to the NPL, depending on the severity of the hemorrhage or the apposition of the retina or incarceration of any other of the retinal tissue. So we all know that the incidence very depend on the procedure. In the PPV, it accounts for about 0.2 to 2%. It is a little bit higher from the phaco emulsification, and it's much lower in the in the large wound cataract surgery, such as ICCE or ECCE, which is accounted for about 2 to 3%. So, but the risk factor that we are looking for is the preoperative and intraoperative. We have to look into if the patient has advanced age, atherosclerotic risk, any glaucoma or myopia, aphakic and pseudophakic, and especially the patient who has the previous suprachoroidal hemorrhage in the last fellow eyes. And during the operation, we have to check if there any sudden drop in the IOP or any uncontrolled systemic hypotension. It can lead to suprachoroidal hemorrhage. So the severity of the suprachoroidal hemorrhage can be classified into 3 stages. The first one is the limited suprachoroidal hemorrhage. It is defined by the limited extension, maybe around 1 to 2 quadrants. At this stage, the suprachoroidal hemorrhage can be spontaneously resolved within just 1 or 2 months after we close the wound. But if we cannot control it, it can progress into the more massive suprachoroidal hemorrhage. It is defined by the kissing of the hemorrhagic CD and leads to apposition of the retinal surface and cause traction or rheumatogenic retinal detachment in the futures. And at this stage, the patient may need a surgical drainage. And if we still cannot control it, it can become an expulsive suprachoroidal hemorrhage, which can cause the extrusion of the intraocular contents outside of the eye. And at this stage, we have to admit that we lose the war. So I would like to highlight the importance of the limited suprachoroidal hemorrhage because, as you can see, that in this patient, it is just a regular RRD, but during the operation, this patient has a hemorrhagic CD, and so the surgeon decided to put silicone oil, and after 1 day, the operation, you can see that the hemorrhagic CD is still there at the 1 to 5 o'clock, but after 1 month, all of the hemorrhagic CD completely gone, and after remove the silicone oil, it's like nothing ever happened, just only the laser scar from the vitrectomy. It is another cases that highlight the importance of the limited suprachoroidal hemorrhage. And you can see during the operation, hemorrhagic CD occurred during the silicone oil filling. As after 1 day, the hemorrhagic CD is still there, like half of entire eyes, and just 1 month, it's completely gone, just the silicone oil. And after remove the silicone oil, it look pretty promising. This confirms that if you can control hemorrhage, it can bring the good result. So this highlights the importance of early recognition and timely management to prevent limited suprachoroidal hemorrhage to turn into the massive one. And so if we can control it fast, we can save the eye. And if we already have the massive suprachoroidal hemorrhage occur, the thing that we can do is we can just control the damage before it's turned into the expulsive one. So there are signs of suprachoroidal hemorrhage that warn us, such as if the patient has the excruciating pain during the operation, you need to be alert of the suprachoroidal hemorrhage, and any other signs of the change during the surgery, such as sudden AC shallowing or any red reflex loss or the black shadow progressing in the back of the eye or the eye become tense. That means that the pressure of the eye increase. You have to be mindful during the fluid air exchange because it can be the infusion can be slip very easily as Dr. Andrew show us, and during the silicone eye extraction we can cause the abrupt change of the IOP during this step, and also the oil injection as well. And other warning signs are the prolapse of the iris that cannot get back, or any lens, intraocular lens that just jump up into the anterior chamber. So the thing that we can do is not to panic at first. Okay, the thing is we need to immediate tamponade all wounds. We need to rapid wound closure. If the nurse didn't bring out the needle or the stitches, you just use your finger to create the direct digital pressure, or you can just inject the high viscosity viscoelastic to tamponade the vitreous. And you need to control 3 P's. The first is BP, second one is IOP, and the third one is pain control. So, but you need to control it fast. So the best route is to give the medicine to be the IV, and you can put the head of the patient a little bit higher in the reverse tendilambar position to decrease the ocular blood flow, and you need to try to have a short communication with our patient to make calm and comfort the patients. And during vitrectomy, as Andrew showed us, you need to check the infusion first. Otherwise, you can create more suprachoroidal hemorrhage, because sometimes the infusion can bury underneath the suprachoroidal hemorrhage. So it is better to check the infusion first before you turn on the infusion or attach, or you can, if it is already off, you can just quickly attach the infusion tube and check if it is inside the vitreous cavity or not. And if it is not, you need to create the infusion the other side that is in the safer place, or put it in the hand port. And you can use the longer infusion torque cannula to get it past the suprachoroidal into the vitreous cavity. And you can use the silicone oil or heavy liquid to create the tamponade before the blood is getting more into the suprachoroidal space, and seal all the incision to create the tamponade effect after the surgery. And for the post-op management, you can use the pain controller or corticosteroid to release the inflammation. And of course, you need to control the IOP. Please avoid using the aspirin or any NSAIDs, which can cause more bleeding into the suprachoroidal space. And you need to closely monitor and modify other risk factors such as any BP or coagulopathy. And there is some role of surgical drainage, which is the posterior sclerotomy and fibrinolytic agent in this case as well. So speaking about the surgical drainage, the operation that we need to do is this posterior sclerotomy, which can drain out the blood and separate appositional CD, and to prevent secondary TRD or RRD in the future. From the study, which is the systematic review study, shows that they drain in the group that have the drainage only can improve can have the mean BCVA improvement more than combined PPV with drainage. So just that would be enough. And ideal timing for drainage would be around 10 to 14 days after the clot lysis. You can use the serial B scan to check whether it is already lysis or not. You can observe the hypoechogenicity turning to the hypocoagicity of the mass after you follow up. And these are the indications for the surgical drainage, such as severe pain, uncontrolled IOP, any persistent fat AC, kissing CD, RD, or any serious organ involvement, such as macular involvement or the incarceration of intraocular content into the surgical wound. And this study also showed that the final BCVA also better in the non-appositional suprachoroidal hemorrhage and the limited one, which is accounting for around 1 to 2 quadrants. And so this highlights the importance of early recognition and the benefit of timely management before it can progress into the massive form. So this is the video of the drainage from Dr. Achala. Actually, we try to drain the suprachoroidal fluid from the nasal side, and at first we put the TORCA, which is a non-valve. I think this non-valve would be the better option, because if you put a valve, the blood cannot pass to it very easily, and we can just put the infusion pressure into the anterior part and use the TORCA to create the sclerotomy. The ideal site to create is maybe around 5 to 6 millimeters behind the limbus. As you can see, sometimes we can use the MVR blade to create the larger wound to bring the blood out. And right now we have some study reporting the role of fibrinolytic agents to accelerate the clot lysis and allow earlier drainage of the suprachoroidal hemorrhage, and it also showed the promising results. The recent study on the RTPA, which is the recombinant RTPA, and many others inject it into the suprachoroidal space around 5 millimeters from the limbus, and dosing can be ranging around 10 micrograms to 100 micrograms, and the role of urokinase type plasminogen activators in the subtinal injection. But these studies are only few studies, so we need larger study at RCT to prove the benefit of this fibrinolytic agent. So this is, I would like to share this case. This case is in the front of this slide. This is a 64 years old female with a lot of underlying disease which is related to atherosclerotic risk, such as diabetes, hypertension, and chronic kidney disease in stage 5. Her EGFR was 13 and was subjected to dialysis. And she was diagnosed with the ankle closure of the left eye and was initially planned for the phaco about 4 weeks ago. But unfortunately, during the operation, BP comes up and patient was really painful, and AC become shallowing. So at the time, the surgeon think that they may be the fluid misdirection, so they did the Richard tapping. But it turns out that they have the bleeding coming from the ciliary sulcus, and the relief was turning dark. So that's why that at the time the surgeon think that it should maybe the suprachoroidal hemorrhage. So they managed very quickly with the IV mannitol, IV sedative, and nicardipine, and close the wound very rapidly. Ultrasound confirmed that there was a vitreous hemorrhage and suprachoroidal hemorrhage at the temporal site, which is luckily spontaneously resolved within 2 weeks. So this at the time I plan to do the vitrectomy with the fragmentome. As you can see, the lens is still there, and do the scalar fixation under the GA to not create more pain to this patient, and put the IV cryoprecipitate in the pre-op. As you can see the video here. Sometimes it may look great because the suprachoroidal hemorrhage is already gone. But after I dig in, can I move the video? I'm not sure. Okay, so let's see. So first I try to rotate, to bring back the vitreous that already trapped into the wound, and put some viscoelastic, and then push the lens back, and let's see if is there any incarceration of the of the vitreous into the wound and check the port if it is into the vitreous cavity or not. And luckily it already into the vitreous cavity, so I do the vitrectomy. As you can see, there's a lot of vitreous hemorrhage and lens is still there. So I push the lens back and clear off the vitreous hemorrhage. Okay, okay. Now I try to create more visualization, and I see that there is some traction at the periphery caused by the apposition of the retina here. So I try to release all the traction from the vitreous and from the retina as well, but I don't want to create more bags, so I just leave it there and clear off of the vitreous, and I clear off the lens. And after I clear the lens, it's just retina and me right now. So as you can see, there's some traction over here and subretinal hemorrhage. So, and I think that it is not quite safe to put the fluid action because it's gonna push the fluid from the periphery back to the macula, which is still on here. So I do the laser barricade over the 360 and just leave the water, just close it with the balance off. Okay. And here's the case. So after 1 month, the laser is become more mature, and the traction at the periphery was going down. So I think that it is quite safe for this patient, and her macula is still on. And after 2 months of follow-up, I do the refraction. The visual acuity was 20/80. So and the retina is going down, and all the subretinal hemorrhage is almost completely resolved. So I think that it is quite safe for the patient to do the scalar fixation. But unfortunately, after one month, 1 day before the scalar fixation, there is some break open at the traction here. But luckily, when I did the laser, the fluid cannot creeping inside of the macula, but creeping just from the inferior part. So that's why I abandoned this operation and changed into barcode 240 and 280 at the temporal side and put oil back into the eye. And here is the visual acuity. Here's the eye. After 2 weeks, you can see I don't want to create more bags, so that's why I put the barcode to support all of the traction, and all the traction were sitting on the barcode very nicely, and oil pushing the brake back. So in conclusion, it is important to identify the high-risk patient early because we don't want to actually have the suprachoroidal hemorrhage, and it is very important to recognize and respond promptly because timely diagnosis and management are crucial to optimize the outcome. And please do not hesitate to escalate quickly, and if you have any suspicious sign of suprachoroidal, just close the wound or call the senior and ask for any surgical support when needed. And 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 as the topic, is there any hope? Actually, the hope is not the patient or disease. It is us. We are the hope for the patient. So remain hopeful. Even in the severe case, timely intervention can preserve structural and functional outcome of the eye. Okay, thank you.
Thank you, Dr. Piranat. Very nice presentation. You highlighted all the importance and the timings, and it's one of the gravest complications which no one wants to have. So we have any questions from the audience of the panel?
Two questions.
Please.
Excellent presentation, sir. Two very basic questions. What is the ideal site of external drainage for massive suprachoroidal hemorrhages post-operative, and how do you determine it?
Okay.
What is the site of the drainage? Is there any role of B-scan or any other thing that you use?
Okay.
And second would be, can you answer the first question first?
Okay, so normally I would use a non-wounded Tokai cannula, and I just put it in like around 15 angle to be slightly parallel to the sclera to ensure that it is not going to go into the vitreous cavity. So if I begin it at this stage and it doesn't come out, I will put it out and do a sclerotomy. So the largest sclerotomy I have done is around 3 millimeters. Mm-hmm.
So any particular quadrant you prefer, or any quadrant would work for you?
It's just the highest side of the suprachoroidal hemorrhage, and
so I think B-scan
yes,
is going to be the primary indicator, like that's the primary investigation that you rely on.
yes, it's very helpful.
On that, then what would be the ideal time of drainage that you would prefer in massive suprachoroidal post-operative hemorrhages?
Normally, I would do about 2 weeks. I would wait for the clot lysis, even though from the ultrasound shows that it become the hypoechogenicity. I still wait for 2 weeks in order to let the clot to lysis completely.
And as you mentioned in your talk, there were some cases in which you extracted the hemorrhage 3 to 5 days after it happened. So
Mhm.
when was that? Was it completely dependent on the use of TPA, or there were some other factors which were responsible for you to decide that particular
No, no, no.
intervention?
It depends on what type of suprachoroidal hemorrhage. We also divided into two types, intraoperative and delay. In delay, we usually seen it in the post-glaucoma surgery. At that point, you can just drain it just one day after this, or maybe 48 hours after the surgery, because you need to close over the like leaking wound of the glaucoma. You can just drain it at that point. But if it is like from the cataract or vitrectomy, I would just wait for for 2 weeks. But I have to admit that I don't have any experience for using any fibrinolytic agent at that point. Yeah.
Thank you. Thank you.
Thanks.
So since we have no questions, I think we can conclude our session. And I would like to thank all of you for joining us in the last session for APAO. I'd like to thank all my speakers for joining us, and we can conclude our session. Thanks a lot. Yeah, we can have a photograph.